Welcome back to another episode of the CritMedic podcast. I'm your host, Dominic Wallenczak, and today we're going to be talking about pulse oximetry. Is it the greatest tool ever, or is it highly overrated? Well, that depends on who you ask. Stay tuned, and we'll cover that and more. So, when we're talking about pulse oximetry, one of the things that people typically think of is the rote number for pulse ox level, whether it be 98% or what percentage. But that's not really what we're going to talk about today. We're going to talk about everything but. So let's talk a little bit about pulse oximetry. Now, pulse oximetry has a rich and storied history going back to Carl von Friedort. Now, this is a little bit of a history lesson for you folks, but Carl von Friedort actually was the inventor of the sphygmograph, which is an early precursor to the sphygmometer. So he was the almost inventor of the blood pressure cuff. Along the same lines, he was the almost inventor of pulse oximetry. He was the very first to notice that that the spectral light frequency changes when it's exposed to circulation. So he found this to be actually fairly interesting, and he let the entire scientific community know about his discovery. And the notification went something along these lines. Now, this was back in 1876. So I can imagine the conversation went something along like this. So he notified the scientific community. It was a passing interest, but there wasn't really a lot practical that they could do with it at that point, unfortunately. The technology really hadn't progressed to a certain point where they could actually do something useful until World War II happened. Now, World War II actually progressed medical science in a number of ways. One of those ways just happens to be pulse oximetry. So, World War II had a special need for pilots who were flying at high altitudes, needed to monitor their oxygen saturation levels so that they could avoid hypoxia. This was actually a known killer to Air Force pilots, or I should say Army Air Corps pilots. So they developed this early pulse oximeter that actually clipped onto the ear, or I should say more of screwed onto the ear, and used two color filters for light. It used a red filter and a green filter, and they were able to deduce from there an actual oxygen level. Now, this was implemented in some early stages, but never really saw mass production because it had a number of issues. One of those being, it had to be calibrated for each and every patient or each and every subject that they were testing it on. And now this could be done by breathing 100% oxygen for a little while and then getting the 100% level, and everything else would be below that. But unfortunately, it just wasn't ready for prime time. It was a great theory, and both the U.S. and the Germans were both researching this technology, rather with keen interest, but it never really came to fruition. So, after that point, it stayed dormant for about another 30 years, until the 1970s, when Takuyo Aoyagi from Japan actually created the very first commercial-built pulse oximeter. Now, he actually was trying to research the velocity of cardiac output. That was his actual goal. He used a special green cardiac dye, and he had an ear clip pulse oximeter that he was trying to see how long it took the dye to go from central circulation to distal circulation. And unfortunately, he had this issue where he couldn't quite measure the actual speed because these pesky fluctuations kept on happening with every single pulse. Unfortunately, the pulses can be rather annoying when you're trying to, isolate for controls. So, with pulse oximetry, he noticed that it was actually changing the values with each and every pulse. And he came to realize that, wait a minute, this could actually be used for pulse-by-pulse oxygen level monitoring. Now, he used a green filter as well, because the predominant theory at that time was that, well, the green light, would measure one frequency, and then the red light would be measured at another frequency. But what they didn't realize is that the tissue actually absorbed most of the green spectrum, so it was mostly the infrared that was actually being used as a measurement. So anyways, he posted his findings in a engineering journal and was about to do an engineering presentation on it when another competitor got wind of it over at Minolta. So he was the first to market. Minolta patented their pulse oximeter less than a month after he patented his. Unfortunately for them, their patent was invalidated because it was found that it was patented right afterwards. So in comes the Minolta Oximet pulse oximeter, and to get around the patent restrictions, they actually changed their entire setup. Instead of having a emitting diode within the ear sensor, they actually had it housed in the main unit and using a fiber optic cable. That, and they also had the pulse ox sensor move from the ear to the finger. And lo and behold, they created the world's first fingertip pulse oximeter to enter mass production. So that's it for the boring stuff. Allegedly, I promise you. Now, here's where it starts to get interesting. So, how does this magic number box work? And as I mentioned earlier, this talk is not going to be about a rote number. This talk is going to be about something entirely, well, I won't say entirely, somewhat different, in that we're going to be talking about photoplethysmography, or pulse ox pleth wave, which is decidedly not quite as cool sounding as photoplethysmography. So what is photoplethysmography, or the pulse ox pleth wave? Well, it's the waveform that's associated with the finger sensor, or any other photoplethographic sensor that you want to utilize. And this measures pulse by pulse actual values of what your saturation is. And the reason that this is so useful is that it has a number of uses. Let me get into some of the components of this pulsatile waveform. First of all, you've got your forward flow, which is your initial upstroke. And once it reaches the finer arterioles and branch arteries, you actually have a reflected wave that comes back. It's sort of a water hammer effect, and that creates the little notch. You often hear this referred to as a dichrotic notch. And these come in a couple different flavors. A normal healthy person, you get a delayed reflected wave because these vessels are nice and elastic. And in elderly patients or diabetics or hypertensive patients or those with vascular disease, you get this different looking waveform where the arteries are stiffer and not quite as compliant. So you get an earlier pressure spike in reflected wave. And that's how you get like this offset waveform that you see there in part B. So if you look at your patients, you actually see a lot of the older patients will have the one on the right there, part B, and a lot of the younger ones will have part A. And you can actually subdivide that a little bit further. You can actually divide it into these different classes. Now this is based on arterial waveforms, but the same principles hold true. You've got your class 1, class 2, 3, and 4, and they represent different degrees of health. So it correlates with the arterial waveform presentations, and as you age, once you get over 45, the statistics show that males over age 45, only half of them have a class 2 or better waveform. And when you get down to males over 65 who have a class 4, which is nice, smooth, you don't really see a dichrotic notch, you may see a slight change in the terminal angle, they have a 4-time greater likelihood of having had a past MI when they have a class 4 than when they have any other presentation. So here are just some of the uses of photoplethysmography. Now, you can determine whether you've got perfusing or non-perfusing beats. You can verify whether you've got capture with transcutaneous pacing. You can use it to measure distal perfusion. You can use it to measure hypovolemia, fluid responsiveness. You can use it to check your aortic valve function or look for cardiovascular disease. You can look for pulsus paradoxus or pulsus bisferiens. Vasoactive medications will have certain impacts on this. You can look at different things that affect the hemoglobin, respiratory rate, respiratory effort. This all shows up on pulse oximetry. So let's talk briefly about extremity injuries and perfusion. So obviously different injuries can have different impacts on distal perfusion. And one of the things that we're responsible for EMS is verifying that there is actual perfusion taking place. And one of the things that I like to do is I like to take the pulse ox sensor and put it distal to the site of the injury. And this does two things. One, you can use it to verify, undeniably that extremity has perfusion. So if anything ever comes down to it, if there's ever a question, any sort of malpractice or tort claim, whether EMS actually had pulses or whether they failed to verify that or something they did caused the loss of pulses through some adjustment or movement, you can say, no, let's take a look back at the uploaded EKG. See this? This pulse ox waveform is from the affected extremity as documented. So you've got 100% proof that there is perfusion taking place. Now, some of the other things you can do, you can look if there's compromise in the vascular perfusion of that extremity versus the other extremity. You're doing things like perfusion index, which is exactly what we're going to cover next. So perfusion index, you may have seen on some monitors, it's a smaller number, doesn't really have a lot of fanfare. And perfusion index actually measures the ratio of pulsatile versus non-pulsatile blood flow and displays that as a ratio. You can go from anywhere from 0.02 all the way up to 20. And these numbers by themselves don't really actually mean anything. You put it on someone who's got a perfusion index of 7. Okay, what do you do with that? Well, what it actually is useful for is measuring variations amongst that individual patient. Variations between patients is not really useful for, but in that one individual patient, if you give them a medication that has some vasoactive properties, you'll see either an increase or a decrease in the perfusion index. Anesthesiologists sometimes can rely on this and say, if they've administered the anesthesia drugs correctly and they don't see a change in the perfusion index, they need to double check because potentially their medications might not have taken hold or might not be effective. What this does in our case for the extremity injury, you can actually compare the perfusion index from the affected side to the non-affected side to see if there's some degree of circulatory compromise, whether or not it's entirely occluded or not. So it actually has, quite a beneficial use in that respect. And it also gives you an early indicator of if your patient's distal perfusion is actually starting to decrease, an early indicator of shock, if you will. So perfusion index is another useful tool that pulse oximetry has for you. Now, determining perfusing versus non-perfusing PVCs, I have better EKGs of this. For some reason, I keep on forgetting to upload them. But this is just a common image that you can find here, displaying a couple PVCs here in an EKG, and it has looks like both an arterial and photoplethysmographic waveforms. And you can see that all the beats here, all the normally conducted beats seem to have a nice crisp waveform associated with them. But the PVC really does not have an appreciable waveform. And you could use that as evidence to show that those PVCs are not particularly perfusing. I think one of my favorite case examples of using this technology to demonstrate perfusion was a call I had actually several years back now. We get called to evaluate a patient who has a visiting nurse on scene reporting bradycardia. So we walk in and do our evaluation and verify, yes, there is indeed bradycardia present. So we put them on the EKG. However, when we put them on the EKG rate shows a rate of 88. That's not bradycardic at all. But it doesn't really match the radial pulse rate. Now, this patient had a ventricular paced rhythm, and then it had another wide complex right after it. But it looked a little bit different. So after piecing together enough 12 leads, what we were able to figure out is that it looks like he had a reentrant ectopic beat right after the paced beat. Now, the pacemaker doesn't know whether it's perfusing or not. It just knows that electrical energy has been delivered to the ventricle, and as far as it's concerned, it's satisfied. But when you look at the actual pulse ox waveform, you'll notice that just like the example here, you don't really see a pulsatile waveform developing with each PVC. So he's in bigeminy, but only half the beats are actually getting through. So his palpable pulse rate was in the 40s. So we took our patient to the regional medical center and reported our findings to the triage nurse. They said, well, what's the heart rate? Well, that kind of depends. You see, the EKG says his heart rate's 88, but you see his actual perfusing rate is 44. And unfortunately, that explanation got lost in translation because the number that was entered into the chart was 88, not actually his heart rate. So we're told, oh, go ahead and just put him in a cart in the ambulance waiting area. All right, well, we could do that for now, but I still reported to the attending physician, hey, look, I have objective evidence here showing that his actual perfusing rate is 40, not 80 as documented. And you know what? A room in the primary ER was actually opened up for him so that he could receive the care that he needed. So this can make a difference in your patient care. Some of the other things that you can get from a pulse oximeter is you can actually get the respiratory rate. Now, this has been cleared in Europe for Massimo to use the respiratory rate through the pulse oximetry, but it hasn't quite been approved yet in the US through the FDA. It's one of those things where we're lagging a little bit behind on allowing some of these early adoption technologies. And how it does that is just based on the respiratory cycle, as you can see in the waveform. These respirations cause intrathoracic pressure changes, and these intrathoracic pressure changes impact cardiac output. And the changes in cardiac output show up in the pleth wave. So you can see in the examples here, you've got changes in kind of cyclical variations in the waveform, both the arterial and the photoplethysmographic waveform. So we can actually use that to calculate respiratory rate ourselves. Let's take a look at this example over here. So as you can see, the auto-interpreted rate based on the respiratory impedance from EKG leads shows a rate of about 21. So let's get rid of that for a moment here, and let's do some math here. You can see that the spikes that I've highlighted here actually seem to be the tallest ones. Seems to be kind of a little bit cyclical, and those two appear to be peaking just above the top waveform, the top line there. So when we count those out, there's 5 EKG spikes in between, from one to the other. So take 107 divided by 5 is approximately exactly 21.4, which is pretty close to the calculated rate of 21 that we had as we saw earlier. So we can use this to monitor respiratory rate if we were so inclined. I know a lot of times we'll just visibly observe our patients to actually get a respiratory rate, but let's say you're charting afterwards and you say, oh, hey, what exactly was the rate at that time? If you've got a EKG strip with a pulse ox waveform, you can actually calculate that out for yourself. Now, one of the other things that you might be able to see is the pleth variability index. Now, this is a Massimo-specific patented technology, and they've trademarked the name. But what pleth variability index is it's measuring the difference between the highest peak and the lowest peak. And that's really just showing the variability between the waveforms. Now, this is fairly useful at determining patients that might potentially be fluid responsive or might be a little bit hypovolemic. Now, this has some limitations, as we've discussed. These changes do occur naturally with respiratory cycles. But just like using the sniffing technique in ultrasound, if you have a certain degree of vascular changes with respirations, you could easily argue that they could be a little bit fluid depleted and could benefit from some therapy. So in a meta-analysis, it really seems to be held up. There have been a couple of studies that show maybe it's not as sensitive as we would think, but an overall meta-analysis seems to be fairly favorable. So pleth variability is a tool that you could potentially utilize if you have a Massimo pulse oximeter. And this is actually something that was discussed in Kelly Grayson's article over on EMS1. Him and Jeff Poland actually collaborated on a very nice piece about, reading by hand the pleth variability and determining whether a patient needs, whether the patient actually needs a little bit of fluid resuscitation or not. So, this is a really nice article. I managed to throw in a little bit of 2 cents in there as well. So it was nice to be published, even as a footnote at the end, though, even if they did misspell the name at the end. So, moving on, let's get into some of the other EKG-associated findings that you can find. So, when we're talking about pulses Bisferians, it's associated with the Bernoulli's principle, and that signifies aortic valve dysfunction. And you essentially get a double tap of the felt palpable pulse. Now, I'll be honest, this is a very fine finding. It's very difficult to be able to palpate something like that. But what's not quite so difficult is to be able to see something like this on a photoplethysmogram. I have seen this on patients more often than I've actually palpated. To me, it just feels like one particular beat, but if you're very well honed in your physical assessment skills, you might be able to actually pick up the double tap of the pulses. And along the same lines, this looks like a double tap, but this shows a IABP waveform here as well. So the intra-aortic balloon pump is a device that goes into the aorta and inflates right essentially where the dicrotic notch would be. And the goal of this is to decrease the afterload that the heart would pump against with the next cycle, and also kind of provide some support to the coronary perfusion pressures, as well as some forward flow to improve overall perfusion. So this is 1-to-1 triggering here, and you can use this to supplement your assessment for whether the IABP is triggering appropriately and correctly. I wouldn't use this by itself. I would use it in conjunction with, say, the actual art line, which is far more sensitive, but it's just an extra piece of corroborating evidence. Anyways, pulses alternans. Now, this is something that you might actually be able to palpate, but is even clearer on arterial and photoplethysmographic waveforms. You see different amplitudes of the pleth waveform with each beat. So you see high, low, and it alternates. And this is actually based on the Frank-Starling principle, which is the heart is not really effective at having that initial ejection, so it has a lot of residual. So when the heart actually has more time to fill, the heart actually stretches more, and that greater stretch provides greater cardiac output, which is why the next waveform actually shows up as a taller peak. And then afterwards, after a normal cycle, again, you get the weaker output, and the cycle repeats. So this is really indicative of some left ventricular dysfunction. And some other measures that may potentially be useful for pulse oximetry technology is pulse carbon monoxide. Now, I think everyone is probably familiar with the RAD57. It's gone through some evolution since then, and Massimo is now included in the rainbow set technologies that you can find in your Zoll E-series or your LP15s. You could even get this, I believe, with the E-series as well from Zoll. But pulse carbon monoxide is a useful tool, especially when you go for those CO alarms, and you want to see and verify that these patients aren't exhibiting symptoms and have findings consistent with CO poisoning. Now, as some would point out, there's some outliers where the patient may present with falsely high or falsely low readings. So just keep in mind that there's always some limitations with any equipment that you use. Another use would be pulse hemoglobin. And this is something that can be found on some of the newer pulse oximeters, like your Prontos or your Radius from Massimo, where they have the ability to actually not only measure how much hemoglobin is bound by oxygen, but how much hemoglobin is circulating in total. And this can be useful as a spot check to see if someone needs a formal laboratory assay to see what their hemoglobin level is. It's an early indicator. But what's kind of interesting with the way that Massimo markets this is these devices have a certain number of uses that they are allowed in order to be used. So you buy a license for X amount of spot hemoglobin checks, and as you use them, the device actually counts down. So you take an unlimited device like pulse oximetry, and they found a way to actually make it an incremental expense. So another useful measure is pulse methemoglobin. Now, certain medications can cause methemoglobinemia. And a lot of these medications are even ones that are sometimes carried in many EMS organizations. So, don't you think it might be useful to be able to measure and test for this common side effect of these medications? I think so. So, be on the lookout for whether your monitor is capable of measuring pulse methemoglobin. Now, there's other different exposures that can cause methemoglobinemia, but it's just another tool in your pocket, another way that you can use the pulse ox to your advantage. Now, I'm also bound to tell you that there are some limitations to pulse oximetry technology. Some of those limitations are poor distal perfusion, usually related to cold extremities or hypoperfusion or shock, or even just peripheral vascular disease in the elderly. So you might not always get a good pulse ox pleth wave. Things like nail polish may potentially cause some issues. There have been some studies that show that there's not necessarily as much issue with nail polish as once previously thought. Anecdotally, from personal experience, I have experienced some issues with nail polish, but as the saying goes, anecdote is not equal to data. So one of the other things that can cause issues is light interference, particularly with the newer rainbow set technologies that actually use many more light frequencies. Things like LED lights with electronic dimmers can introduce enough electrical noise to cause significant artifact. And last but not least is obviously motion artifact. Your elderly patients with a little bit of Parkinson's, or your pediatric patients, or your patients who simply just can't stop fidgeting with the pulse ox sensor, you're going to have a significant amount of artifact on the photoplethysmographic waveform, to the point that sometimes it might not be usable. So what is the takeaway here? What is the too long didn't read version of this presentation? Well, the basic premise is that pulse ox is to arterial saturation as the pleth wave is related to the arc line. They're both quick, non-invasive equivalents of their more sensitive and specific cousins. And lastly, if you're going to get a cheap pulse ox, just a cheap little finger pulse ox from eBay or Amazon or wherever, make sure it has photoplethysmography, because you can use this tool to your advantage. At the very least, you can always use the pulse ox pleth wave to verify that you actually have an accurate pulse oximetry reading. I can't tell you how many times I've gone for a patient who is hypoxic at some SNF or LTAC facility, and you get there and you put them on your pulse ox after a little bit of adjustment. Now you've got a pulse ox reading with a good pleth wave, and their saturation's perfectly fine. Well, what typically occurs in those circumstances is that the staff had put on a little pulse oximeter, didn't wait to ensure that they have a good, clear waveform, or perhaps their pulse oximeter doesn't really have that. They may just have the signal strength indicator bar graph, which is kind of a one-dimensional representation of the plethysmographic waveform over time. So if they didn't assess to make sure that they have a good waveform, that number that they get isn't reliable and cannot be trusted. You can't depend on a pulse ox pleth wave or pulse ox value if it doesn't have a good crisp pleth wave. So lastly, know the tools of your trade. If this is your chosen profession, and You want to treat your patients to the best of your abilities. You really need to make sure that you know the ins and outs of all of your tools, just like any mechanic would know the ins and outs of any crescent wrench or any pair of pliers. So, know your wrench to the best of your ability. And remember, until next time, keep thinking differently.